Thank you again, the organization, for inviting me to this meeting. Now I'm going to talking about anticoagulant, antiplatelet breathing. I don't have disclosure for this talk. Anticoagulant, antiplatelets are different. Anticoagulants, or ACPs, is an inhibitor of the coagulation cascade. It's normally used in venous thromboembolisms and atrial fibrillation, and has a specific antidote. Antiplatelets is an inhibitor of platelet activation and aggregation, normally used in arterial and coronary disease, and not rapid reversal agents. Every year, we have more elderly people in every country. It's a demographic shift. And most of them have anticoagulant and antiplatelet treatment for their comorbidities. And the reality is approximately 20% of the anticoagulated patients require invasive surgery. And you have to decide what is the more risk, the clotting risk or the bleeding risk. In this patient, prior surgery, we have to decide the balance between the risk of embolism or thromboembolisms or the risk of bleeding during the surgery. So it's a balancing thromboembolic protection and surgical hemostasis. Breathing normally uses years ago, using heparin between stopping the treatment and the surgery. And now, after the talk, we have to decide if this have to do it, don't do it, or sometimes you do it. 10 years ago, there is a strong trial, the call is a bridge trial, that demonstrates the no realized breathing therapy, not increasing the bleeding risk or not increasing the arterial thromboembolisms. So only in extremely risk patients, in extremely risk scenarios, you have to do it. Only in mechanical mitral valves or in the 3 months after stroke is completely necessary breathing therapy. And what about the ARU guidelines? The guidelines always say us how to do it, and say they individualize rather than standardize the breathing therapy. Because the bleeding risk is dependent on the processor. We have 3 techniques in endourology, so shock-wave lithotripsy, URS, PCNL, and have different bleeding risk. The major complication in shock-wave lithotripsy is severe subcapsular or perinephric hematoma. And we know, it's still demonstrated, that aspirin is an independent predictor for renal hematoma formation. So the guidelines give us some recommendation about the AP films, AC films. We have to stop every treatment with different times of recommendation. If you do that, you can perform shock-wave lithotripsy without problems or safely, and we have some publication about that. Opposite URS is the most safely technique in endourology. We have only less than 1% of the patients have a subcapsular hematoma, so it's very safe in terms of bleeding, this kind of technique. So if you can choose this technique in this kind of patient, is the perfect option. In this case, it's very recommended to use it a ureteral accessit because it decreases the intrarenal pressure, so it's more difficult to have bleeding after the URS. So the recommendation changed in this technique because you can do it without stopping the AP pills. Only 24, 48 hours you can stop the AC pills. And we have many publications about the safety of the URS in anticoagulated patients. In the opposite is the PCNL, is the major bleeding risk, is normal. We have to perform a renal puncture, it's a renal trauma, and we have to be extremely delicate in stopping the anticoagulant and antiplatelets treatment. And in that case, in warfarin patient, we have to choose to make the breathing therapy in front of the rest of the scenarios. But if you do this kind of prevention treatment, you can perform percutaneous in this kind of patient. So what is the take-home message for the anticoagulants and antiplatelet therapy? First, you have to change your mind. 10 years ago, we know that the routine breathing therapy increased the risk of major surgical bleeding without offering superior thromboembolic protection. The most important thing is the technique that you choose, because the bleeding risk is very different between them, and always you can choose the URS is the best option for these patients. For those patients. And always individual care, and the EAU guidelines say that we have to individualize the risk for the different illness period in those patients. So final remarks, if you have a chart with all the recommendations in endurology, is that you can see in the chart is very separate of very different techniques. So you have to have very different recommendations in these patients. Thank you so much.